As the High Court examines the constitutionality of the president's reform bill, we're examining here what a social welfare model means for the money in the healthcare system. What economic consequences could social welfare bring? In today's Reaganomics, is the U.S. at risk for becoming the next France when it comes to healthcare? Let's find out. Joe Antos is a member of the Congressional Budget Office panel of health advisors and scholar at American Enterprise Institute and the man behind the healthcare plan. We have him with us, former White House special advisor on health policy, currently at the University of Pennsylvania. I want to welcome Ezekiel Emanuel. Good to see both you guys. Joe, let me start off with you. What do you think is wrong here with having a national health care mandate?
Well, the problem with the mandate is that it's not so much about getting people to have health insurance. It's about finding ways for somebody to pay for somebody else, as your reporter pointed out. And there are cleaner ways to do that if we really wanted to accomplish that.
Hang on one second. I mean, because it is a big problem for society that you have so many people that don't have health insurance, Joe. I mean, why not say we're all going to save money in the long run if we don't have people, with skyrocketing medical bills in emergency rooms? If you have some kind of subsidy in effect, why not?
Well, the fact is that we're not going to save money in the long run. The point of this bill is to provide sort of a gold-plated insurance package to effectively everybody. That's the objective. It won't meet that. As everyone knows, our health system is woefully inefficient. We get a lot of services that have really limited value for patients. We get a lot of tests and so on that are driven partly by fears of malpractice and so on. Mm-hmm. That's what we're buying into. So we're buying into a really expensive, inefficient system. Really, the debate isn't so much about having people covered as how we're going to pay for it.
Okay, let's talk a little bit about the European model, Zeke. I mean,
wait a second. Let's not just accept what Joe said on face value. First of all, Joe and I agree that we have a very expensive system that is inefficient. The Affordable Care Act spends a considerable amount of its effort and provisions to try to increase the efficiency of the system, to try to get doctors to integrate care, to deliver higher quality care, to get rid of problems like hospital-acquired infections, unnecessary and preventable readmissions. So the bill focuses a lot of energy on that. Second, one of the important things is getting everyone in the system so that we can deliver good, coordinated care. It's important to get people into the system because many of the people who are outside the system are using care very poorly and in the most expensive manner rather than having it uncoordinated.
Yeah, no, I won't argue with that. But let me bring this point up to you, Zeke. I mean, you look at the European model, right? And you look at the salaries that our doctors are making in Canada or in France, for that matter, and you compare them with salaries here in the U.S. The U.S. is significantly higher. Zeke, do you worry at all that people will not be as attracted to this profession, that you will not continue to gain the top talent because people will not see it as lucrative?
First of all, we are spending 40% more than the next highest country, which is Norway. We have plenty of room to move and to deliver more efficient care. Second of all, I think as many of the reforms are structured, they do something which doctors have really wanted to do for a long time, which is to have more autonomy over how they deliver care rather than to have to deliver the things that are being paid for. And I think that's actually, if you ask most doctors, that's the thing that they are most frustrated by.
You think European doctors have more autonomy? Joe, do you believe that?
Frequently they do in how they deliver care. And let me say, you're putting out France there. Let's be clear. On the last assessments of quality of care, overall, that's not to say that they don't have, our peaks aren't as good as France, but France's quality overall is as good as the United States, and it's substantially cheaper than the United States.
Joe, do you agree with that? Do you agree with that statement? Do you think that that French healthcare is as good and as economical as what we have here in the U.S.?
Well, let's put it the other way that most people talk about
the answer
this.
is yes, because he's hesitating.
No, not at all. I'm just trying to rephrase the question so that people can understand it. What most people believe is that European countries do better in terms of health outcomes, and they spend less money. So let's address the do better on health outcomes. If you take out the health outcomes related to accidents and violence, and you look at what the healthcare system does for diseases, we're every bit as good as the best European countries.
Excuse me, Joe. Just take a look at asthma. The United States adult asthma, as an example, ranks fifth from bottom of the OECD countries in terms of mortality. When we look at people at 65, their longevity, which gets rid of accidents and violence, turns out that American women are 16th in the world and American men are 12th in the world. It doesn't, and France is higher on both scores. It doesn't seem to me you can just say it's violence and it's
no, I didn't say that's the
accident. Hang on, Zeke, back to you for a second. Let's just call it what it is. Here's what the fear is. People on Wall Street are concerned that if you have too much government involvement in the healthcare sector, that will mean less innovation. It will mean less investment going forward, and consequently, our healthcare economy will suffer. How do you respond to those concerns?
So now we're shifting. Is the quality going to be better, and are we going to actually control costs to, are we going to have innovation?
But innovation and quality, those go hand in hand.
Let me just say, we're going to have an explosion of innovation, and here's the explosion of innovation we're going to have. How can we do better health care for cheaper? How, for example, can we keep patients out of the hospital by doing better on home monitoring? How can we reduce hospital infections by redesigning the hospital system? Can we design
But you think the government
MRIs?
will do a better job at that than private
No,
industry?
I don't think the government's going to do that job. Remember, the individual mandate doesn't mandate people go into government programs. Half of the people who are going to get insurance are going to go into the exchange where they get private insurance. What they do is the government gives them a subsidy to buy private insurance. I'm all for the market. I think we need a market-based system to drive innovation, and I do agree that it's important to have a private market in many areas of the healthcare system. I'm all for that,
so
and I don't think the bill.
I want to clarify.
Wait a second.
This.
The bill. Let's be clear. The mandate in the bill does not say you get government programs. The mandate in the bill says you have insurance. You can get insurance through your employer in a private market. You can buy it in the private market through the exchange. The majority of the healthcare system is going to remain private, and hospitals aren't becoming government-owned. Doctors aren't being employed by the government. That is a canard, and I wouldn't think that your Bloomberg viewers would understand that we are maintaining a private system. This is not going to British National Healthcare Service. That is simply a lie and a canard.
Okay, Joe, get in there.
Let's talk about our national health system. Let's talk about Medicare. This is a law that made no real improvements in the Medicare program. We're still paying on a fee-for-service basis. We're still paying on a fee-for-service basis. There are a lot of ideas there that, frankly, we've been talking about for decades.
And we finally put them into action.
No, not
accountable care organizations.
We put the words in the law.
Bundling.
Accountable care organizations are HMOs and drag. Except without the ability of the doctors to actually control what their patients get. So if you want an HMO, that's not what that's going to produce for you. The idea that you can continue a fee-for-service payment system in Medicare, where a huge percentage of our national health funding is spent. You can keep that system and say, well, what we'll do is we'll just lower the payment rates and somehow you'll be more efficient, but you still make more money when you provide more
let's go back to what
gentlemen,
you and I agree.
Leave it there. They've got the music going. It's our cue to leave it there. But terrific discussion. Zeke, I hope you'll come back on the show and talk some more because we don't want to leave this alone. Joe, a pleasure to see you. Great job, guys. Thanks so much.